keep your audio and video muted during the presentation. And also, at any point of your time during the lecture, kindly drop your questions in the chat box and it will be addressed by the speaker immediately after the lecture. Here also I am having Ms. Anjali Arya, who is from the sales team, who is the fulcrum of arranging this meeting and will be helping us in the logistics. And going back to the program, today we have with us two eminent physicians who will be discussing on two important topics. Initially, I would like to invite Dr. Ubendra Kaul, who's Dr. Professor Ubendra Kaul is currently Chairman, Batra Heart Center. At the same time, he is also the Dean, Academics and Clinical Research, Batra Hospital and Medical Research Center, New Delhi. So no introductions is needed more than this for Dr. Kaul, as every one of you know about him. And you will be more willing to look at how he is going to do the presentation on complex case of LMCA with TVD in cardiogenic shock and ACS. Professor Kaul, I will request you to take on the stage. Thank you.
Sure, and thank you very much for organizing this very important educative meeting. And I'm going to share a case which was a challenging case, and I'm sure that it will have many learnings. So let me start with the case. So this is the case as was already, and that title was already discussed. And this is a 69-year-old gentleman who was brought to our casualty with history of prolonged chest discomfort, dyspnea. He was drowsy. In history, his son told us that he had a myocardial infarction in the past and was carrying an ECG also, which was managed in his village, well away from Delhi. He had not been thrombolized that time. Well, he is a hypertensive. He was a hypertensive, was taking amlodipine and beta blocker bisoprolol, a diabetic on oral hypoglycemic drugs, and was also on aspirin. His heart rate was 86, which is little, unusual for a patient in shock and other things, but he was on beta blockers. Blood pressure was low. It was around 80 millimeters. This was the ECG showing atrial fibrillation and old inferior myocardial infarction. You can see the Q waves in 2/3 AVF. The echo, which was done in the casualty, showed a very low ejection fraction, 30%. Inferior valve was akinetic, and the other valves, especially the anterior valve, was severely hypokinetic. So he was really a cardiac cause for hypotension. He was straight away admitted to CCU, started on inotropes. His output was low. A fluid challenge was given. He was given a liter in 30 minutes. Blood pressure just came up by about 5 to 10 millimeters. Urinary output remained very low. Hemoglobin was 10.5. His EGFR was 33. The sodium potassium was all right. His troponin was quite elevated, and BNP was 2,100. HbA1c was 8.5, indicating a sugar which had not been well controlled in the past. So he was, according to our diagnosis, in cardiogenic shock, high risk ACS because of all the features. He was a diabetic and had chronic kidney disease. Now, if we classify cardiogenic shock as per the SCAI definition, the A means, this is the ABCD scale. A means stage A, the patient is at risk. Any patient after myocardial infarction who is has signs of no signs of cardiogenic shock but is at risk for development. That means any big MI, any anterior myocardial infarction, is at a risk. B means beginning of cardiogenic shock. A patient who has clinical evidence of relative hypotension or tachycardia without hypoperfusion. C means a classic cardiogenic shock, a patient who manifests with features of hypoperfusion, means, peripheral oligemia, low output, cold clammy extremities, sweating, needing inotrope, or a mechanical support in the form of an intra-aortic balloon pump, or if you have higher grades of support systems, that is class 6C, which is, high mortality situation. Then you come to deterioration, or what is called as doom. A patient that is similar to category C but is getting worse in spite of all the inotropes and whatever support you're giving, and he is continuing to worse. That means his output is falling, his pressures are falling. And stage E means extremist, a patient who is in cardiac, circulatory collapse and is refractory, kind of, he gets cardiac arrest and you're massaging him, he comes temporarily, goes back. So these are some of the stages. Now, how does one manage cardiogenic shock following a acute coronary syndrome? We know that there is a role of early revascularization. It is very clear as per the guideline, and we have this article by Judith Hodgman, done a lot of work on this, and suggested that the only way to is to revascularize these patients, and if you are able to get over the acute condition, the benefit persists beyond 6 months, can go up to 12 months, and this particular study was followed up to 6 years. The mortality in the beginning is high, but benefit of revascularization when it comes persists long term, and this study was done up to 6 years. So, class 1 recommendation of both the European Society and American College of Cardiology of 2019 is that immediate earliest revascularization. And if you compare it with medical treatment, clearly it is much, much better. Now came the other question: should we revascularize only the culprit vessel and then stage the other vessels if it is a multi-vessel disease for a later time, which can be decided upon by the the person who is looking after the patient? What are the pros and cons of culprit vessel versus complete revascularization? Pros for complete revascularization will be that it will lead to better improvement of the jeopardized myocardium. After all, other lesions, if they are significant, and it should lead to improvement in clinical outcomes. But there are some negatives for it, that while you are revascularizing the vessels which have not produced that problem, you may get more ischemia during dilating them, or during the opening them, or during stenting them, and that ischemia could be detrimental. Plus, you're going to use more volume. It's going to cause volume overload. And then contrast. These patients are usually can be compromised renally. This patient, as you see, was there compromised. And then in low output stage, you can get into a renal shutdown and then complicate the whole issue. So it was then this thought that culprit vessel angioplasty is better, and the study very clearly showed that there was a significant clinical benefit of culprit lesion only strategy, not only for 30-day mortality, but also the renal replacement therapy. If you combine the two, which is very important, 46% for PCI versus 55%. If you do multi-vessel angioplasty in the same sitting, the mortality and the renal problem is more than 50%, whereas it is significantly lower, still high, about 45%. And it is mainly driven by an absolute 8% reduction in 30-day mortality. Benefit is consistent and is sustained at 1 year with an absolute reduction. So routine immediate multi-vessel PCI in cardiogenic shock, as per the current guidelines, is a class 3 indication. You should not try to do it. Now, this particular gentleman was immediately taken for coronary angiography after hydrating, and when she was not improving at all. And this was his angiogram. You can see that in this particular aleocaudal view, you can see calcification. You can see there's a severe lesion on the circumflex. You can see here that left main near the bifurcation has a problem, and this is the circumflex which is coming out, which is badly diseased, and obviously this looks like the culprit vessel because this is much tighter. But then, unfortunately, the origin of it is at the bifurcation of left main. There is a disease there and calcified. You can see the collaterals filling the right coronary artery. And if you see the other view, the cranial view, you can see the very tight lesion in circumflex. And then you can see that LAD has some disease, but after the ostium is not so badly diseased. You can see other view also, non-critical disease after the ostium, but at ostium, the left main bifurcation, as we had seen, is disease. And you can see large right coronary artery, which obviously is supplying a kinetic area. This is the right coronary artery. You can see this branch supplying some twigs towards the left system. You can see that. So in short, he has left main disease with all the three vessels involved, severely calcified arteries, a severe to moderate LV dysfunction. He is in shock. He is a diabetic. And if you calculate the syntax score, it was 35, coming to more than 33, indicating that it is really high risk. Intra-aortic balloon pump was straight away inserted from the left groin. We still don't have a Impella and other devices. So this is what we had. So we put in an intra-aortic balloon pump. Surgical team obviously was consulted. They did not want to operate on this very high risk patient, and reasons are very obvious. Now, which is the culprit vessel in this? We already saw that circumflex is the most severe lesion, but then it's associated with significant densely calcified left main coronary artery lesion. And one can make sure that if you put in a wire, it's not going to go here, and it's going to be very difficult to cross this. So what we planned was PCI of circumflex, and since left main distally was involved, there was no way but to do the left main and then the post-ostial left anterior descending. We used the standard guiding catheter XB 3.5. Ostial LAD lesion, as was expected, could not be crossed even with the smallest balloon which we had. So there was no way but to debulk the lesion. And debulking the lesion, we had no experience of debulking lesions in a cardiogenic shock situation, because rotablator bar, when it revolves at that rapid speed, can lead to particles going and can further lead to a slow flow, which this particular patient would be very difficult to manage with. So you can see the intra-aortic balloon pump in C2. And then this is a 1.5 bar which was used. Everything was done rapidly. And then we wired the circumflex and took a balloon, as you can see, to dilate the circumflex. And you can see at a very high pressure also, there is some waste just distal to the ostium. Then we have brought a small balloon there and are inflating this to make some space, because stent has to go in from there and in a very calcified situation. And now finally we're able to position a stent. Is a long stent, I think a 38 millimeters long, aerodhemous eluting stent, 32 millimeters, sorry, and then we've inflated it, and luckily we're able to expand it at a very high pressure. And then brought a short balloon and doing a proximal optimization, what is also called as the pot of the proximal portion here. And then we had to go to the LAD to cover this ostium. And since we had done a pot here, the stent would be totally, it won't be able to cross it like that. So that we had to pull out this jailed wire and then recross the LAD and dilated this portion. And again dilated the ostium. You can see this curve indicating how stiff the root was. And you can see this dense calcification at the undersurface of the left main. Now we're getting in a stent. This is again a 3 to 32 millimeter stent. Same balloon brought proximally and dilated to make, the bed for the left main. And now we're taking another stent up to the ostium of the left main, because there's no way that we can keep it somewhere in the left main. So up to the ostium. So we took many views. I'm just showing this particular view where you can see the dot is just proximal to the ostium. And this is a 4 into 28 millimeter stent. We know that left mains are always big, so there's no point of taking 3 and 3.5. So straight away 4 into 28, and which got quite well expanded. Now we recrossed the circumflex. Now it was not so difficult after doing a part of this, opening the struts and put in 2 balloons there, 3.5 into 15 and 3 into 12, and did a prolonged kiss here, very high pressure. And then again, 4 millimeter pot here to expand the proximal portion. And then finally took a 4.5 millimeter short balloon. It's not a very short balloon, I think a 12 millimeter balloon, which is going from the left main, just proximal to the ostium, over the ostium of the left main, and a little bit into the aorta to, expand the ostial portion of the stent on, so that it is sort of very well opposed to the ostium, like we do in a renal stent. We always take a balloon and then flare the stent. That is the term, flaring the edge of the stent. And now it looks reasonable and quite good, in fact, quite reasonable. It looks quite good. You can see the circumflex, ostium, the left main, and the stent is only up to here. There is some disease distal to it, but there is no point to touch this. And obviously, there's a mismatch also. So I think these are the final pictures. So patient shifted back to CCU. He was stabilized and IABP had to be kept and slowly weaned off after 48 hours. Blood pressure became much better. He was off inotropes. Output started increasing because of the improvement in the cardiac output. Patient was kept on dabigatran and aspirin clopidogrel because he has a permanent atrial fibrillation, which needs anticoagulant. He was discharged after 8 days of his angioplasty. The serum creatinine was significantly lower, and GFR from 33 has gone to 40. And 3 months later, when we saw him, he was class 2, ejection fraction was 40%. And there was improvement in the regional wall motion of the anterior wall, although full heart failure treatment was given. So now let us come, what does the guideline of, tell us about managing some patients, such patients. Now, A and B, that is patients who are at risk or beginning of a cardiogenic shock, intra-aortic balloon pump is advocated by all. And if you have an Impella kind of a device, some people say that this is the stage when you should put an Impella. Class C, that is classic cardiogenic shock, intra-aortic balloon pump, as we know, gives only a passive support. So there is no point, is not going to help. So Impella is the answer. And then more than that, I think an ECMO, that is a complete cardiopulmonary bypass with membrane oxygenator and a pump. We know that Impella is a device which can be put in like a pigtail catheter, and this is connected to a pump and can provide 4 to 5 liters of blood per minute. And then you can do your angioplasty, high-risk angioplasty, and keep the patient on Impella till the time you think that the hibernating myocardium, stunned myocardium recovers, and then you slowly. Extracorporeal membrane oxygenation, is like putting in a patient on go, but this is much more compact. That is, you take the venous blood, take it through the pump, take it through the oxygenator, and get back through a large sheath, about 17, 18 French sheaths into the aorta. And then the patient is on bypass, and you can do a procedure and you can keep the ECMO on for a few days till the time the patient, you can wean it off. What about randomized support devices in cardiogenic shock? It is challenging, and like with Impella also, you can see that many of the trials which were started had to be continued because of low enrollment. Nobody, the people who had Impella will not like to, not use it, they would rather use it. So most of the studies have been, discontinued. If they're completed, they're very small number of patients, and one or two studies are still ongoing. So we don't have the final answer, which are the patients who benefit by Impella. And similarly about the ECMO, randomized controlled trials of ECMO in cardiogenic shock, there are two of them going, large studies, sufficiently powered. EuroShock trial, 420 patients, and the other study is the extracorporeal life support in cardiogenic shock by Chile, again more than 400. Now let's see the ESC guidelines for cardiogenic shock management. Cardiogenic shock complicating a myocardial infarction, and obviously straight away the echo should be done and see what is the ejection fraction, and also to see whether there's any mechanical complication like ventricoseptal rupture, mitral regurgitation, free wall rupture. And then after finding out that the ejection fraction is low, emergency PCI of the culprit vessel is a class 1 indication. No doubt about it. Straight away take the patient to cath lab. And most often we do an angioplasty because they are too sick, but if you have an aggressive surgeon and you think that angioplasty is not going to work, surgery could be offered. And then we give them first fluid challenge to increase the pressure. Invasive blood pressure monitoring is always desirable. Never rely on non-invasive blood pressure because there's a peripheral vasoconstriction. And some people even advocate pulmonary artery catheterization, although this is a 2B indication. But measuring the wedge pressure and seeing whether the patient needs volume or patient needs inotrope, this can be useful. And then ventilatory support according to the blood gases. You should have a good critical care team, and if the gases are poor, depending on the PCO2, PO2, you may have to ventilate the patient. And then intravenous inotropes to increase the cardiac output are usually given. And as a rule, it should be norepinephrine, not dopamine. That is, the guideline says. In presence of persistent hypotension, you use norepinephrine. And ultrafiltration in refractory congestion not responding to diuretics. An intra-aortic balloon pump, as we had used, is clearly a 2A indication. And if the patient, you can wean off the patient like we could do. If you're not and the patient is deteriorating, then you have to use mechanical supports. And finally, if you have a mechanical support and patient improves, then slowly wean off the patient. So the take-home message, what I would like to suggest is that PCI in cardiac shock is feasible even in most complex situations and can be life-saving. And lesion modification in a very densely calcified lesion can be done, and rotablator can be used even during shock, even if it is necessary, because if you waste your balloons, you're wasting time and they're not going to even cross. As you could see, even crossing the lesion was a difficulty in such a severe calcification. And culprit vessel angioplasty, as has been advocated, may not be the best concept in all the cases. So don't go by the book that you do only culprit. In this situation, doing only culprit was just impossible. Fluid balance, judicious use of inotropes are very, very important. And supporting the circulation with whatever means you have is extremely important. Guidelines of which patients at what stage need ECMO, Impella are still not clear. Studies are going on, and obviously if the patient is very sick and has got a very low output and you think he's salvageable, one of the support systems is important. Impella is easier, it can be used in the cath lab, whereas ECMO means putting the patient on extracorporeal circulation. So that which support device for which patient, I think we'll have some guidelines within a few years. Thank you very much. So I'll stop sharing the slides, and you can.
Thank you very much, sir. At present point of time, we don't see any questions in the chat.
Yeah.
If anybody wants to ask a question, you can open up your lines and ask now. Or you do have one more option also. We have, after the second lecture, we will be able to interact with Dr. Cole again, because during the discussion session, he will be available to discuss and answer your questions. So in this situation, now go to the next lecture. And I invite Dr. Professor Mohan Nair, and who is the head of Department of Cardiology, Holy Family Hospital, New Delhi. And he will be talking about an interesting topic, VT storm in patients with CRTD. So we jump into electrophysiology and invite Dr. Mohan Nair to take the stage. Sir, please.
Dr. Mohan, please. Mohan, you are muted, I think.
Now, is it okay?
Yes, yes.
So it's always a great honor and pleasure to share podium with Professor Kaul, who's been guide, mentor, teacher, everything. And as chance would have it, I don't know whether Dr. Kaul remembers, but the first ever ablation procedure done on an EnSite system on Indian soil was when we were working together in Fortis.
Yes.
Fortis, Noida. And there was a patient who was transferred from Gangaram by Dr. Mantri because he was on VT storm. And the whole night before the procedure, he was getting shocked by the residents. And Dr. Kaul said, "Ye kahan se udhon ke le aaye patient ko." So I'll tell you what happened to that patient. Later, he really told me that, "Aur koi nahi mila kya aapko?"
Dr. Nair, we have lost your audio.
Mohan, we can't hear you.
Yeah. Dr. Nair, are you able to hear us? Your audio is not there. I think he is rejoining, sir.
Okay, no problem.
Yeah. Is it okay now?
Yes, sir.
But my slides, yeah. So is it fine now?
Yeah,
yes,
we can hear you very well.
Yeah. Yeah. So this is a 60-year-old male with dilated cardiomyopathy.
Share the
excuse
slides.
me. Yeah.
Class 4 symptoms.
Sir, please share your slides.
I'm on share.
We are not able to see it, sir.
Oh, okay. I'll have to do it again then. I'm so sorry for this.
Yes, sir. We are able to see.
Thank you.
Yes, sir.
So this is class 4 symptoms, dilated cardiomyopathy on digoxin, diuretics, ACE inhibitors, and beta blockers. Had 3 hospital admissions in 4 weeks.
Sir, again, your audio is lost.
He is unmuted, but we are not able to.
Yeah. Sir is not muted, but we are not able to hear you.
Now can you hear me?
Yes, sir.
Yes.
Now, yes. We can see you and hear you, sir.
Yeah, okay. So this combination is refractory heart failure with left bundle branch block with LV dysfunction and NSVT on Holter is a class 1 indication for a CRTD device. And he did get a CRTD. This was the QRS to begin with. As you can see, it's a broad QRS, left bundle branch block. And then he had this device. You can see a defibrillator lead here, a very well placed left ventricular in the and posterolateral vein and a screw-in lead in the atrium. Now, post-CRT, this ECG is not very clear, but what is clear is that the LBB is converted to RBBB with an AVR being positive. You see an RS in V1, and the QRS duration certainly has decreased to about 103 to 110 milliseconds. 4 days following implant, the patient became class 2 of intravenous medications. The ECG, as I showed you, was narrow, and the LVF improved to between 30 and 35%. And this is typical for a lot of patients where we put a CRT, and most of the studies, for some reason, the symptomatic improvement far outweighs the numbers that go up in LVEF. The average LVEF or a median LVEF improvement that you can expect is about 60%. But a lot of patients do become hugely symptomatically improved. And there was, if you see, this is the X-ray before the implant. After the implant, you see that the heart size is also decreased. So patient remained asymptomatic literally and was very happy for 5 years. Received 2 to 3 appropriate ICD shocks per year in the first 5 years. Then he presented recently in July 2020 with 3 to 10 shocks per day. So anything 2 or more shocks per appropriate shocks per day qualifies to be labeled as VT storm in a patient with ICD. Or of course, if the patient doesn't have ICD, any 2 or more shock, 2 or more VTs, hemodynamically unstable, requiring DC cardioversion also qualifies for a VT storm. Device interrogation showed that there were appropriate shocks, and this is very important because in the previous patient also you saw, as you have patients with LV dysfunction, it's a good chance that the patient has atrial fibrillation, and several of the shocks could be inappropriate because of that. And that another point that is cannot be overstressed is that these patients do much better with a dual chamber ICD because that atrial lead is extremely useful for diagnostic purposes. Just to put on record, the first ever dual chamber ICD paper, which was published in Circulation, I was the first author. I was working with, it was the Defender trial with ELA Medical. And there we realized how much of these AFib problems could be easily taken off. So the inappropriate shocks in such patients would be about 20% at least. With single chamber ICD, it decreases to about 5%. And even those can be programmed to have appropriate shocks. So what are the options? You add amiodarone. If the patient is already on amiodarone, there's even among electrophysiologists, there is a divergence of opinion. Some people say the patient is already on amiodarone, then it could be pro-arrhythmia and you stop. But I honestly feel that amiodarone never causes a VT storm. So if there's a breakthrough on amiodarone, 100% my approach is to step up amiodarone and reload. Then you need to step up beta blockers, sedate the patient as deeply as possible, sometime even requiring general anesthesia. Again, you need to work on the cardiac sympathetic uh, innervation, and a good idea is to do cardiac sympathetic denervation, which can be easily done. Temporary cardiac sympathetic denervation can be done by thoracic epidural anesthesia. We just put in I'll show you some pictures. But in this patient, for some reason, we were not able to do it either because we didn't have an anesthetist who could do it. But any anesthetist worth his name should be able to put in a small cannula into the epidural space, except in patients who are on dual antiplatelets, that's with ischemic cardiomyopathy. Now, this was not done here, but all other things were done and they all failed. Catheter ablation clearly is not available everywhere, and catheter ablation is certainly not the first choice. The first choices are the ones which I've said here, and I think it's a good idea to have this checklist and also have some anesthetist who's trained in cardiac sympathetic denervation by a thoracic epidural anesthesia. Now, what are the challenges in catheter ablation of VT in an idiopathic dilated cardiomyopathy? Most of these VT shocks or VT ablation in patients with low ejection fraction is a challenge because you can't repeatedly induce and shock the VTs and map VTs, except if you have a slow VT. So everybody agrees that the first step should be to modify the substrate. There are scars. I will show the pictures. Bell Stevenson's basic brilliant paper, which showed the scar substrate and how these circuits lead to VT, different VTs in these patients. Now, this is Bell Stevenson's unbelievable work. Actually, it showed how complex the circuits can be. And the key is to be able to find out these small channels which are essential for the VT and be able to ablate. What is now done in a substrate modification is to try and electrically isolate these complex areas. And it's fairly simple to assess, image, and then plan such ablations in a patient who has ischemic VT, because you know the MIs he had, you know the areas which are ischemic, and you know where to expect the scars. And the scars are pretty well, can be identified. For example, in this patient, there's a very small scar here, the white area, and then you just give carpet lesions on the scar, and that's it, totally electrically isolated. Most of these patients would be expected to have one morphology VT. The other is to where you have a larger scar, and again, the scar is not causing the VT. The VT is going around these channels. Now, again, for the students who are listening into this, there is this beautiful article from Nakagawa, which says, no channel, no VT. So if in a scar you don't have a channel, then there is no reentrant circuit. So these are the channels which make these scars being able to sustain reentrant circuit and areas of slow conduction. So what you do is what is called homogenization of the scar. Now these are these islands of border tissue. You just make a scar here, and then the whole area is a homogenized area. There is no inhomogeneity. If there is no inhomogeneity, then that tissue is rarely arrhythmogenic. So you'll see here that we've just taken out this channel and there's a continuous scar here. Now, again, the challenge in these patients, even if it is ischemic, is the more you ablate. I know people do endocardial ablation, then epicardial ablation. That does lead to a further reduction, can lead to a further reduction in ejection fraction. So an extensive scar homogenization, endo-epi, works very well in patients who have a ejection fraction about 40%. And in those patients, some of them actually you can just do a substrate modification, not even put an ICD. This is the worst large anterior MI, multiple morphology of VTs. There's no way you can isolate this whole scar without causing problems. So you then look for these small channels again. You see these small little bridges of border healthy tissue, and you just ablate here so that the scar becomes more homogeneous. But in idiopathic cardiomyopathy, the MRI shows scars, but it is patchy. And you don't know where to look for scars. And really, even on the MRI, the scar does not correlate with the area of origin of VT. And then, of course, with a ejection fraction of 20% and having already received so many shocks, the ejection fraction comes down further. And these patients are actually very, very difficult to take on table. Some people have used, I know for sure, that they have put these patients on ECMO. And there's a New England Journal of Medicine paper, which is very nice. They just put the patient on ECMO to see if on ECMO they could do the ablation. But the moment the LV was decompressed, there was no VT. And that case report is actually about how on ECMO the VT storm was taken care of. That's a good idea. But again, not always feasible. You need to do a VA ECMO. So this patient, now what we have is, I don't know whether it's very clear, these high density mapping catheters. The one from Abbott is called the HD grid. Now the HD grid, honestly, is a wonderful catheter because if you can, I don't know how clearly you can see, it's a 16 electrode mesh. It's so soft that if you go into the LV, uh, they say you can just paintbrush through the entire LV cavity, get the cavity uh, anatomy, and also the voltage and activation maps. And of course, coming more to the details, these are perpendicular bipoles. So you don't have what is called as a wrong scar annotation because it takes of the two perpendicular bipoles, it takes a higher voltage. So it is actually taking voltage that is going parallel to the electrode and not perpendicular to the electrode. And people say, and I believe this, it's impossible to damage a cardiac structure with this HG grid mapping catheter. So what does the HG grid show? You see the same thing. It's here, the HG grid is being mapped. And these are the purple, you see thousands of points taken within a few minutes, even less, few seconds maybe. And you see a whole lot of purple, which is the high voltage area. And then when you turn, there is this long channel. There's a full scar here just under the aorta. And there seems to be an area which is borderline or intermediate voltage area. Sometimes, at least with the HG grid, when we started using, we know that the voltage criteria that we are used to in the LV, which is zero point 0.5 to 1.5 millivolts is marked as scar, needs to be tweaked. And in this system, you can really tweak it up and down just to see where you start seeing areas of uh, intermediate voltages and areas of scar. So you can see here there's a long, narrow isthmus. The VTs are going around like this, like a figure of eight. Most often the term is used in atrial arrhythmias. There's this long channel, and this black line is what we ask the clinical assistant or clinical helper of the NAVIC system to mark it out for us for our ablation. Now we don't want in these patients to induce VT upfront and then shock and map and shock and map and shock. No, I don't think anybody does that anymore. It's much better to do a substrate modification, then induce. If you there's a good chance that you will not induce any arrhythmia because there is no substrate for arrhythmia anymore. Second, even if you induce, the VTs tend to be much slower because they have to go through these areas which you've already destroyed with RF ablation. So that's the plan we have. And then, of course, if there is still inducible or if you're not happy with the potentials that you got on the endocardial map, you can go epicardial. Epicardial, again, because you need to be continuously irrigating, you must always be careful about causing a tamponade purely with the saline that you're irrigating the catheter with. And these patients, again, are extremely sensitive to all these things. We've had patients where we have had to stop an epicardial procedure because the patient's BP fell down. We took out all the pericardial fluid, the fluid that we had injected in a irrigated tip, then again go. So these are challenges in these patients who are critically ill. Now, if you see here, we had this, as we were ablating, we had this clinical VT induced, and you go on ablating, and at some point, the VT just disappears. And these are, of course, the pacing spikes made by the ICD, which is always put on a VOO mode during an RF ablation procedure. So this was the spontaneous VT during RF delivery. And as you continued the radiofrequency, see this bad looking RBB notched, typical of a very much diseased myocardium, those VT. And when you give the RF ablation, you terminate the VT here. And this is what it looks once you have taken care. It looks pretty nasty. And I'm again saying that one has to be very careful about not doing too much because you can really end up having a patient who has a dip in ejection fraction and comes back to you with not with VT, but left ventricular failure. And this patient, again, we tested with the device and even on an RNT VT induction with the device, there is no just a short run of VF, no sustained VT. And we try to actually end up with no VT induction. If you end up with only clinical VT not induced, you have some success rate, but the success rate is best if you have no VT induction. Or you take care of all the VTs that you see on the table, irrespective of whether they have been recorded clinically or not. Now we have 3 months follow-up, a little more than that. There is no VT post-RF ablation. The patient is hemodynamically stable. It's been put on 100 milligram per day of amiodarone. This was a paper we published some time back on radiofrequency catheter ablation of VT in structural heart disease. We had 38 cases, but only one patient of idiopathic dilated cardiomyopathy. And that's why I said that idiopathic dilated cardiomyopathy, searching for the substrate, mapping VTs is a challenge. It's not, substrate modification is fairly straightforward, increasingly in ischemic heart disease. It's also fairly okay now with this high density mapping catheter works with ARVC or arrhythmogenic right ventricular dysplasia. But with idiopathic dilated cardiomyopathy, it's a challenge. And that is why when Dr. Kaul told me koi aur patient nahi mila, I was a bit actually sheepish about it because I didn't know whether it would work. It was the first ever NAVIX case in India. And this patient had been referred because he was having VT but could not afford an ICD. And honestly, and this is what makes it the effort worth it. Not all patients do well. Not all VTs go away, but a good number will have less VTs. The VT storms can be taken care of. And the patient we did with Dr. Kaul sir in Fortis, the first case of NAVIX Insight in India, came back to me after three years, maybe less, when we had by that time shifted to Fortis Vasant Kunj because the cath lab was ready. And he said he had had collected enough money for an ICD. And I didn't know what to do because there was no VT anymore. But anyway, as per guidelines, and because he had the money, and I mean, I said, God forbid he gets a VT, I put in an ICD. And honestly, he's still alive, has used the ICD twice or thrice. Every year he comes from Bikaner or somewhere, I think. Every year he comes, and it's such a gratifying thing to see the patient up and about and has an ICD. Of course, he's used the ICD shock, but it's more than 10 years. It's the kind of patient you would have lost if you didn't have all these technologies available. So I think there are a lot of options available now. And a very interesting option of source, as I said, is cardiac denervation, which you can do temporary by a thoracic epidural, permanently by a thoracoscopic. Uh, you can see the nerves are always on the epicardial fat. So you can see on the along the ribs, T2, 3, 4, 5, and just peel off that epicardial fat with the sympathetic nerve. And I think that Kalyanam Shiv Kumar, who is now the editor-in-chief of JACC-EP, has done it with a couple of centers in India and with rewarding results. So what I'm saying is that we are beginning to understand the neurohumeral axis of these VT storms. We are beginning to understand the substrate. We have almost everything that is, I don't think there's anything that's not available in India that's available somewhere else in the world. And it's just a question of going that extra mile to save these patients. And again, I'm saying not all of them do well, but the ones who do well are really gratifying. Thank you very much.
Thank you, Dr. Mohan Nair. That was a wonderful presentation, and no doubt that you're the pioneer in 3D mapping in India. So wonderful presentation. And you do have a lot of questions in the chat box, sir.
Okay. I thought I will get away without any questions.
No.
So anyway, I think that since Call Sir is there, maybe he can also answer some of the questions.
Unfortunately, Dr. Cole messaged us that he has some other program to go.
Oh, I can see Dr. J.C. Mohan.
Yeah.
So, good evening, sir. So if I can't...
Good evening. Dr. Mohan, excellent presentation. And
Thank you, sir.
I know that this kind of thing, very few people can do, of course, and you are a pioneer. I am proud of you. I have been your colleague for good 17 years, and it has been a wonderful journey actually seeing you doing these cases. Unfortunately, in practice, I'm getting less of such cases because I'm pretty sure that a lot of these people, because of antiarrhythmic drugs, revascularization, better anti-congestive therapy are not getting. But of course, you do see occasionally VT storm. The last VT storm of this kind I saw was, I think, 3 years back. But I'm not sure. Is it a referral bias? How frequently are you seeing VT storms?
We get at least 2 or 3 cases every year for this. Yeah, that's a referral bias, of course. And we do see. I get, the last one we did was about 3 months back. Again, Dr. Chandrasekhar had referred. So I do get these. In fact, our numbers for VT ablation for structural heart disease, because it's so gratifying, is far more than AFib ablation procedures. So we do end up doing a lot of these patients. You're right. If you take care of LV remodeling and you do with these new drugs very clearly, and the way forward with ARNI and SGLT2 receptor blockers, we might see less and less of these arrhythmias. Clearly, absolutely. But I think that also with revascularization and some people with late revascularization, some scars formed, arrhythmias might be the primary problem post an MI, because the scar is always.
Yeah, now that oral maxiltine is available in India, What is the role? Where would you use Maxiltine in these
Yeah,
cases?
as of now, we use it as the last choice. It's a very good question that you asked. I'm sorry that I didn't know you would be there actually. So I took the liberty of not putting it on the slide, and I've been caught. I knew I would be caught. I'm sorry for that. Yeah, Mexiltine is an excellent alternative that's easily available from Cipla in India. And before we start planning an ablation, all these patients would be on Mexiltine. Some patients who have slow VTs going on, sometimes they don't have any inducible VT on the table, but they have next day VT, they are again on Mexiltine. So Mexiltine as an, I should have put it on the slide. I'm sorry for that.
Thank you, Dr. Nair. You know, I actually long for working with you again. Maybe you can find a job for me close by. So
Anytime, sir. Anytime. You don't need a job.
thank you.
Thanks, sir. Thanks, sir. Yeah, I can take some chat questions now.
Yes, sir. There is a question from Dr. Santosh.
Yeah.
You stand on MRI or PET prior to taking on ablation for VT for substrate localization. Sir, how much area we need to target to ablate in cases of large areas of scar?
Yeah, that's a good question. Some people I have seen do a lot of scar modification. You know, they keep going, and I don't want to name the operators. They go endoepicardial in all patients, endoepicardial on all patients, and but we are very conscious of this. And when I've talked to, say, even Narsiman, we are all scared about the way some people just keep going on ablating. So we carefully try and look at channels. If you can find channels, then your ablation area is much less, and you are ablating in and around a scar. You're not going into the very healthy areas. So we actually, in fact, that large anterior MI that I showed, that patient had 8 different morphologies of VT. We could have spent hours trying to isolate that big scar. It was much more gratifying to have done just small ablations in the channels. So I think you have to spend time and, like I said, tweak the settings. Don't be fixed on the settings that are set. And with HD grid, we are learning that because of um, uh, the perpendicular bipoles, the HD grid sometimes doesn't show any scar at all because it is looking at the higher voltage. And we change the settings and look for channels. You can invariably find. But again, the patient in whom the last patient we did with Dr. Chandrasekhar had sent, we really couldn't get anywhere. We couldn't really find any channels despite using HD grid and spending some time. And then we had to just go and ablate the most common clinical VT in the left ventricle outflow tract. Sometimes we have to do it, but we are very careful about not ablating. Bombarding or carpet bombing the entire LV. That I don't think does work.
So there is one more question.
Yeah.
Which patients you will go for epicardial ablation upfront, especially in dilated cardiomyopathy?
Yeah, this is a good question. If you go through the literature, it depends from one center to the other. And I have seen that it is between 11 to 30% that people have to go for epicardial. I know that there are some operators, including Andrea Natale, who do routinely all patients have an endo-AP. We don't do that. Our own use of epicardial is more close to 11 to 15%. And my reasoning is that in the thinned out areas of the scar, if you use a contact force irrigated catheter, you can give a transmural lesion without having to go epicardially. So we go epicardially as the last option when you've done a good substrate modification endocardially, and then there is still VT. We've done epicardial, and then that's sometimes extremely grateful too. because the VT which was just not going. Or if on the entrainment, on the diastolic potential, or the entrainment map, you find that the entrainment is not good of a VT endocardially, you go epicardially, immediately you find that there's entrainment. So that means that the critical stenosis was epicardial, is easier to go epicardial. So I think we go about let's say maximum 15% of cases we do go, even in dilated cardiomyopathy, epicardially.
So one more question. Does
Yes.
parasympathetic stimulation with carotid sinus massage is of any help, at least partially, in cases of VT storm?
No, I don't think so. I don't think so. And all the literature, but you could be wrong, because that's one area which is extremely interesting, which we are learning. And that's why I said that people who are not ablating also should look at these things, because we are getting increasing information that the innervation to the heart, the central nervous system, heart axis. I had a slide on that. I did not show it because of the time, but there's a huge role for um, autonomic denervation of the heart. Carotid sinus massage, I don't think anybody has reported, but you know that people are reporting even renal denervation for VT storms. So you can try. I mean, it's a kind of uh, uh, no loss situation, because it is a dead end for the patient when he comes with a VT storm. So you try whatever you can, and maybe in one patient, some patient, the carotid sinus massage might work in some way. I have no experience and I've not read about it, so I've never used it.
So we go from Dr. Santosh to Dr. Rajendra Gupta. His question is, does a new drug, omecamtiv, which is a cardiac myosin activator, helpful in preventing VT?
Which is the drug? Come again?
Omecamtiv.
No, I've heard about this, but no experience. It might decrease. I have no experience, honestly. I don't know whether Dr. J.C. Mohan knows about this drug and VT.
Omecamtiv actually is being tried in a trial called Galactic HF. Galactic HF is a HFrEF trial where the drug is being used. It basically is a myosin stimulator.
Yeah, that I know.
Myosin stimulator, but that it can be used in VT, never heard of that.
Yeah, so it might have a secondary impact on decreasing VT, like you said in the initial phase, that drugs which act on improving cardiac function or act on cardiac remodeling might finally have a big effect on VT, surely.
Yeah.
Even with CRT-D, if you see, in fact, once when Horatio came, I said, if you have money for only an ICD or a CRT-P, which one will you use? And he said CRT-P. And I didn't believe him at that time. But now I know that if you have a CRT-P for 6 months working, then you know that they don't have any shocks anymore. So many of them don't require a defibrillator. Yeah. So if the choice is between a drug or the therapy to improve cardiac function or cardiac remodeling structure, then that will definitely impact. But direct impact of this drug on VT is yet to be shown.
Yeah, we just had in ESC this presentation called Save ICD, and they showed that people who are already on ICD, and if you give ARNI and those you don't give in a randomized fashion, there can be up to 25% people who don't use ICD at all, and you probably could get out of that thing. That number may be probably with the passage of time become bigger, but the fact is drugs do help.
Absolutely, no question about it. The first step is to treat the heart failure, and the first step is not to look at the electrical impact very clearly. Yes, Sabri.
Anybody else has any question, or else we will conclude? So there is no more questions. So for my Thanksgiving speech, I eminently teachers who have been helpful in conducting this program, we thank you so much for preparing these presentations and presenting it so clearly These two studies by both the speakers have thrown a lot of light to manage difficult situations. And also subsequently, the discussion also has taken up a lot of information about various difficult situations. I also profoundly thank Dr. J.C. Mohan for giving his valuable inputs and to all the participants to take the time and be part of this education feast. With this, we conclude the education program, and thanks to every one of you for safeguarding us, and we take leave today, and we would like to hope you to see again in another education phase. Thank you very much.
Thank you very
Thank
much.
you, Dr. Mohan. Thank you, Dr. J.C. Mohan.
Thank you. Keep sending me the link whenever you do such a program.
Yeah, and
Sure, sir. I do.
please don't hesitate to be a visiting consultant to our unit. It will bring so much of value. You know, we are just rotting there.
I definitely, I sorely miss you. The intellectual conversations we had, I really
Yeah,
miss
of
it.
course.
In fact,
I keep talking about it. So hopefully, maybe Abbott should bring us together. You know,
yes,
more often.
yes, that is true. That is true. Thank you very much.
Sure,
Thank
sir,
you very much.
definitely.
Thanks a lot. Thanks, Sabri. Thanks, Anjali. And of course,
Thank you,
Dr.
sir.
Paul was there. It was
Thank you,
wonderful.
sir.
And
Good night,
thanks
sir.
everyone who joined it. It was wonderful interacting with all the people, and I can't individually thank everyone, but it's absolutely marvelous connecting to these young, bright minds. Thank you very much. And have a
Thank you,
nice
sir.
weekend. Have a nice weekend. Thank you.
Okay, sir.
Thank you, everyone, for joining today's session. Thank you. Good evening. Bye-bye.